severe just by biomarkers that you can take a picture and see microaneurysm, irma, hemorrhage, anything. And now we still have fluorescein. Fluorescein is still good. And now the fluorescein is wide. We can see the periphery much better than the 7 fields in the ETDRS. And the things are changing. We can call this peripheral retina ischemia. That's if you have more than 35% of the periphery ischemic, you can tell that this patient is ischemic. And this can tell you that this disease is progressing. Even if you look in the fundus, the macular area, all clean. But if you have ischemic in the periphery, this disease is progressing. Look that, it's beautiful picture. And if you see, we can add more laser. We have so many good area for laser in the far periphery, but sometimes not easy to cover everything. And autofluorescence. Autofluorescence is something that is gain each day more value in our work. And if you think diabetic makes stress, make the inflammation inside the cells, and RPE is inflamed, they don't work well, they accumulate lipofuscin, and if you have the background very hyper fluorescent, means that the disease is progressing. This easy, just a picture. We can say, oh, we are not going, we have to come back here many times to try to check. But OCT biomarkers, OCT is incredible. Everyone love to take a picture of OCT because so many information you can get with the OCT. We have the thickness, the volume of the retina, and we can say that what kind of edema, macular edema you have, and we have the prediction of if you have the disorganization of the layers of the retina. And let's talk about the macular. We have more than one type of edema, like the sponge edema. Sponge edema is something very frequently, you can see that. And this sponge edema is driven more by VEGF, respond well to anti-VEGF, and it's not so bad like the serous retinal detachment. That's more inflammation when you have this kind of serous detachment. And it's not so frequently, it's around 10 to 11%, but that goes well with anti-VEGF. And cystoid macular edema. Cystoid macular edema is one edema that makes the vision drops a lot. Sometimes we have to combine anti-VEGF or steroid, or maybe if you have focal leakage, laser. Laser is still alive. And tractional edema. This tractional edema is maybe the worst one or not, because you can clean this with vitrectomy and the patient's gonna be very well. And just to review, we have the sponge. You can laser or pharmacological. Cystoid, basically pharmacological, but you can use steroid. And serous detachment, that's more inflammation. Steroid helps a lot. And tractional vitrectomy. And the predictive biomarkers. We have one that's incredible, that we call disorganization of retina inner layer as a predictor. We call DRILL. DRILL was if in the 1 millimeter center in the fovea, you can't see the internal layer of the retina, means that this cells is disorganized or dead. And then, even if you treat this patient and all the fluid's gone, maybe the vision will not come back. And now, these external lines. When I start the first year fellow, I try to teach him all these layers, and they have to be in mind this, because everyone means one type of cells. And if you see these three lines here, is the photoreceptor. We have the external plexiform line. We have the nuclear external and ellipsoid. Ellipsoid is part of the photoreceptor. Look again. We have all these three lines. That's very important. And if you have a disease like this, you can treat, and if you're like gonna get better, but the vision is not better. This is a patient of mine. He was count finger. After I treat him, he's 2200. If you see, have drill and have no ellipsoid line, means almost the retina is atrophic or dead. And hyperreflective foci, this is a tiny point, less than 30 microns, and has no black shadow, and they can migrate from outside to inside the retina, and mainly in diabetic. I mean in diabetic, because DME is, the macular degeneration is different, is microglia cell. It's inflammation. And this spot say that we are progressing the disease. If you see here so many spots, and they tells you that we have inflammation inside the retina. At the beginning, they can respond to anti-VEGF as well as steroid, but with time, steroid gonna be better than anti-VEGF. Look here, this patient used dexamethasone or ranibizumab, work well in both, but if you see, the dexamethasone was much better. And this just saying that maybe is equal. There is no statistics to use one versus the other, but many people think the anti-VEGF, steroid gonna be much better for hyperreflexive foci. And here we can combine most of the biomarkers. We can have the drill, we can have absence of the external lines, we have subretinal fluid, and hyperreflective foci. All these are progressive and predictive biomarkers, and may say the vision gonna be worse, you have to treat. And now we can go for OCTA. OCTA is a very good tool, and we are learning. It's a new one. Nobody has in the clinic yet. It's expensive, but if you tell me if I use everyday clinic, no, I don't use. I have only one in one of my clinics. I don't have this for every patient, and it's expensive. And in Brazil, the insurance company don't cover for all patients, and then I don't use every day. But they have very good information that we can discuss here. Like, if you lose the foveal avascular zone contour in irregularity, or the caliber of the vessels is less, or the density of the vessels is less, everything can tell you that we're gonna progress the disease. We don't have anything, but if you take this picture, if you have enlargement of the area, they mean that we're gonna progress. This biomarker is good because even before we have hemorrhage, we have microaneurysm, you can tell, these patients have to be very well treated because it's gonna progress very fast. A circularity, it's beautiful, no? If you see that the fovea avascular zone is a circle, it's good. But start to be a monster, this thing's not going good because it's gonna lose vision very soon. Ischemic. Circularity, predictive positive correlation with progression. And the density decrease. You have the superficial and deep capillar. If you have in the deep capillar, if you lose vessels, mean the density of the vessels is ischemic, mean that this patient gonna progress very fast. Look here, especially in the deep capillar plexus, if you lose vessels, you mean progression, ischemic. And the 3D is when you got these vessels, it's the same idea to see the same thing. You say, or we're losing vessels. If you're losing vessels, you're gonna be ischemic, you're gonna progress, and even if you sometimes treating with laser, this patient going bad vision. Okay. Let's say that geography can help to use anti-VEGF. And this, the last one I want to tell you is the external limitante membrane. External limitante membrane is very important. If you have broken on the external limitante membrane, means that we are losing photoreceptor. And maybe if you have a huge cyst, this huge cyst is compress the photoreceptor, they destroy the photoreceptor, and you can see this by the external limitante membrane line. All this mean progression. There are just cover. And wide field fluorescein comes to help you. Fluorescein is still good. We should use, but we use less frequently because we have OCT. Structural OCT that's very popular is very good with a lots of biomarkers that can help you to tell the patient if the disease is going to progress, if the vision is come back or not. Or OCTA, that's not so popular, but comes with so many new biomarkers that helps you. I have to say thank you. Brazil and Pakistan is far, but now I become very close by heart. Thank you.
Anybody has a comment? Can you just please go back in slides to the OCT angio?
Please. Return the.
I mean, very wasabi.
Yes.
What do you want? This one?
The image on the right. Here there is a cystic changes. So I just want to clarify for the audience that we shouldn't count or evaluate ischemia when we have on OCT angiography when we have cystic changes, because they can be very deceiving. So because of the it gives us this signal voids and the compress of the vascular tissue, so it might give us this view of ischemic, but it could be not ischemia. And as you noticed, where we have the right arrows, especially there's a compression, so we get even have a segmentation artifact in this area.
Perfect.
Just want to clarify this point.
That's correct. The big cyst compress and make this. Yes.
We can move to the next talk. I think
Yeah.
it's also for you.
The next one is the same. Let's restart. This I make up this title, Retina 4.0 or Retina 5.0. That doesn't matter. It's just to this talk is something that I'm trying to understand the new world. I'm trying to interpret what comes. And I don't know if you're going to agree with me. We can discuss this a lot. But many things that's happening here is my vision. I have no financial disclosure for that. Have really think this guy, a dreamer, that makes a lot. In the last talk today, we're going to spend some time telling what's real happened with us during these 4 days. But this guy make the ophthalmology center to be Pakistan. And these things gonna fructify a lot in the future. Thank you so much, Hassan. I hope we can tell this in the afternoon with a crowd audience. And World Cup. This was fun, you know. Brazil yesterday was beat by Croatia, and if Morocco's beat Spain, and whatever. Many game was like this. Cameroons beat Brazil, whatever. But a good thing to note, the world is changed. There is no one that has privilege to be traditional the one. Anyone can win. But why the things is changed? Because we can learn. We have a lot of people smart in the world, not only in the West world, but whole world. The East has so many good people that are learning things, and things are changing. I'll show you how the things change. This is very nice. If you have a chance to buy this book, it's the fourth industrial revolution. This guy, Karl Kleis, was the guy that organized Davos Economic Forum, and this guy has this book that tells you we're in the middle of a big change in the world. And I can tell you, the pandemic time moved this fast. And everyone know by school, the revolution start something like in the 17th century with the smoking machines, and progress to the factories, progress to electricity, and after that for the computer. We have many revolution. We are now in the fourth industrial revolution. And now, if you remember this guy, we have a Moore law. Moore is a guy that said in the 70s, every 2 years, the computer can double the capacity to process, to be more fast. And these things really happened since the 70s until now. And now we can have a big computer in your phone. Have your phone much better than any computer that took the human being to the moon. That was in that rocket. We have a superpower that you can do anything in your hand. This changed the world. And if you remember, in the 40s, huge computer, mainframes computers, is a building with all the computers that process very slowly. And in the 80s, we have Apple that said everyone gonna have a computer at home. We're gonna be more computer than cars. He was right. And this guy have a vision. They said the computer gonna change the way we human being to communicate. But he's not alive, but he was right. And then, this is, I don't know if this is right, but the people from the Silicon Valley used to tell that one day we have the singularity. That means that the human being is gonna have some parts fusion with the machine. We're gonna have the way to put the machine inside your brain. The many companies are working on that. I don't think that's gonna be easy, gonna be fast, maybe more 30, 50 years to have something like this. But we have the Neuralink. It's a company for the guy from Tesla, Elon Musk has a company that try to pursue this, to connect your brain to the computer. And then another good thing is we are living more. If you think in Brazil, in the 50, the average was 55 years old. Now it's more than 70. It's around 74. And some countries 80, and some countries like Japan is pursuing 90. US is 80 as well. But this changed many things. And in the health, I mean, each one of us can get 1 million gigabyte of health information. If you try to catch blood pressure, sugar level, and many things we can get from your body, you can get a lot of information. But as I said, the people are living much more. And medicine, the medicines changed. In the 70s was very cheap. You go to the doctor see you and say, gonna live, gonna die. No more, just pay the doctor. In the 2000, no. We have the doctors, we have new machines, and the resolution start to improve. We're gonna save eyes with PDT, with anti-VEGF, but this thing has cost, and the people live more. And then the market said, okay, now I don't have money. You have to deliver the same resolution with low cost. And I don't know here, but in Brazil, the insurance companies is corrupted. Many are broke. And because they spend too much money, they don't have money, and the people don't have money to pay them, it's crazy. The health system is not healthy. And then I'll just tell you about artificial intelligence that's going to connect with the health system in the more 3 slides. This guy, John McCarthy, was the first guy that was brilliant in marketing. He was trying to organize a meeting like this and say, I have to create a big name for this convention. Let's say artificial intelligence. This was in Dartmouth in 56. And he was telling us how the machine can mimic our brain, that's the perfect intelligence. How to do this. Those days, something like, oh, it's impossible. But they are trying. And how the artificial intelligence help? With big data is one way. We have so many information. As I said in the beginning, we have 1 billion information in your body. How to separate this in information that you can understand? Like you have 1 million files. 1 minute? Wow, I have to run because it's long. And then artificial intelligence have to differentiate apples and orange. Means we have to say, this guy has diabetic, this guy doesn't have diabetic. They're going to help us with this. Have machine learning, all the difference of deep learning, machine learning. One is use a guy to put the information, the other one doesn't need a guy to collect the information because they're going to go by themselves. It's all this to explain this. And then artificial intelligence is going to help you in the clinic, in the research, health system. And now we have the 5Gs that helps this a lot because I have in Brazil that's much more fast than used to be. And Retina is a special place. Why? Because we have image. Image helps a lot. And we have image that's going to connect with the use of pharmacology, genetic with the new genetic treatments. And we have this connection, human being, like the singularity. We have this prosthesis that can help some patients. And in the 60s, this cartoon predict everything. We have already telemedicine in those days, if you see. And the machine learning was approved in the United States in 2019 for diabetic. And everything in Retina is image. And then we're gonna be easy to use artificial intelligence. We're gonna see the image and predict this patient needs more injection or not injection. This can help you about this. Artificial intelligence can help you to say classification, screen disease. This guy has diabetes or not. We don't need you to see all the patients. Or segmentation. This guy has fluid inside of the retina. We have more injection or less injection. Or predict if the patient's gonna improve with those biomarkers that I said at the beginning. And I used to test for a UK company these biomarkers, this artificial intelligence system that's gonna mark all the microaneurysm, hemorrhage, and tells you this guy has diabetic or no diabetic. Does work. And we have all these new handheld devices. In Brazil, I have this company. It's very cheap, something like $3,000. It's very nice pictures. We can connect to the computer in any place by internet, and I can be here, check the patient in Brazil with very few cost. And then I have to tell you, all this is changing because we can get all this information. We have to process this information, and these things are gonna help us to live more. And we should not let the fake news about machine, that machine's bad, machine's gonna destroy our jobs. In my impression, machine gonna connect people. I work on this the last 3 years, and I can tell you, many people here I knew first by virtual space, and make me come here and knew in person. And these things make people connect. Now, I have so many friends from here, and just began 3 years ago in a virtual space, where everybody was at home, and the technology is spreading. We have democratization of the information, and we not has ones that's gonna be for tradition be the first. Anyone in the world gonna come and get new ideas, and I believe the East gonna drive this. We have 1 billion of people here, smart people that work hard, and the West is trying to be in that position. I don't know how long. Thank you so much. So beautiful country, and has
Thank
this
you very
opportunity
much,
to be here.
Dr. George. Yeah. Very nice and excellent presentation. And the last one is something amazing. I think the future, it will be what you are saying. We hope not to be within our times. You know, we cannot cope with this one. Yeah. Any question?
There's no question, there's a comment.
Yes.
You said that the machine inside the body, we already have pacemakers.
Yeah.
And we can have awakeners in the mind, keep you awake for 24 hours, and you work the double of the time.
Yes. Everything is trying to connect that.
I think if you allow me, there is so many things that we don't know about it under investigation, or maybe it is available, but they are not given to us once. Like mobile, I think mobile, it was not in the 90s. This is a fake story. Mobile, it's available before, maybe in 70s. So, but it was for a military purposes, to be honest. Then after that, they finish this one. They have something more sophisticated. They give this one for, and I think it will be other things like this. Maybe.
In my opinion, I've been developing artificial intelligence for a Russian company. I'm their scientific consultant. So I find that it is far, far away to replace us because it does a lot of mistakes. But it can be very helpful to for crude assessment, especially when we're gonna do screening. I think it's the future heading toward that, not toward replacing us. So as you've mentioned, it is useless to think that machines will replace us. It will help us. It will make our job easier, but never replaces us.
Okay, we can move now to, thank you, Dr. George. Thanks a lot. To Amin Marashi, and he will give a talk about suprachoroidal injection novel indication.
Hello, everybody. This is me. Most of you knows me. I'm Amin Marashi from Aleppo, Syria. I am a retina specialist. I have no financial interest in the products mentioned. We heard about partial lump that by Clearside they are producing those injectors for suprachoroidal. It's transconjunctival, minimal invasive, and they made a great studies that showed the efficacy and safety for diabetic macular edema with or without intravitreal injection of aflibercept. And there are the Tanzanite study that showed the efficacy and safety of this procedure for macular edema related to retinal vein occlusion. And we have this the Peachtree study that by its results, the phase 3, they gained the FDA approval for treating macular edema related to non-infectious uveitis. So, of course, all those studies were for triamcinolone being injected into the suprachoroidal space. Can we inject something else? Yes, of course. There is the axitinib, which is being injected in the suprachoroidal space. For whom is not familiar with the axitinib, it's pan VEGF inhibitor which block the VEGF receptor 1 and 2 and 3. And there are being the RACES study that assess the safety and tolerability of a single dose of the axitinib in the suprachoroidal space, and found it is tolerable, no serious complications, and with a long-acting potential, which reduces treatment burden for a neovascular AMD, and we can utilize it into the gene therapy. As you know, we cannot inject the stem cells directly to the intravitreal. I think in the United States they did it, and they had yes, they had bad results. So they said we do a vitrectomy, we detach the retina, and we inject it submacula. But when the suprachoroidal injection was introduced, they started to inject those stem cells in the suprachoroidal space. So it turned from expensive invasive procedure to in-office procedure. I have the microneedle, but I don't have the stem cells yet. So I would like to test them, but I don't have them. So what they did, they injected the RGX 314, and they did the phase 2 of the Aviate trial for treatment neovascular AMD, and the phase 2 of the Altitude trial to treat diabetic retinopathy. And they found that in both the trials, 47% of patients treated with the RGX 314 demonstrated more than 2 steps improvement from the baseline diabetic retinopathy severity scale at 6 months, and when comparing it to the control group, none has improved. So it showed promising results. What about oncology? Well, Dr. Hussein and I, we were testing to inject melphalan to the retinoblastoma. But due to the pandemic, we stopped because we lost follow-up of those patients. Now there are trials which injecting AU011, which is a photoactivated via non-thermal infrared laser light to induce cell membrane disruption, acute cell necrosis, and a long-acting anti-tumor response. This is the AU011 via suprachoroidal administration in patients with choroidal melanoma, and preliminary results support the positive safety and tolerability profiles. Okay, Do we need the clear sight injectors? Do we have to pay this hefty price for them? No. The idea is very simple. We all can create our microneedles. The limit is the sky is the limit. So the idea, this is my model. I allow only 1000 microns of the 30 gauge needle out, and I create my stopper. I have a combined rubber with the plastic because in my experience when I used to do other materials, they are painful. This is less painful for the patients when I do the injection. I mount this rubber stopper from the plunger from the 1 cc syringe into this lower lip, which I customized and cut it in order to take out, sorry, only 1000 microns. So it's very simple. You can do yesterday if you were in the talk. There are several designs and they all work very well. So we are not here. The best thing, we are not tied to the companies. So I did my own research, my own trials. A girl came to me. She's 17 years old. She was doing a selfie. This is the first time I learned that when you look at the sun and you're doing selfie, you'll have a colorful eyes. So she was looking at the sun while she's doing a selfie, and she did a solar retinopathy. So after consulting with her parents, she's 17 years old. We waited 1 month, and she still has a scotoma. It didn't improve by itself, and we after discussing with her. And with her parents, we decided to do a suprachoroidal injection, and she regained vision 2020 and resolved all the scotoma, central scotoma. Another study I did, which as we for retina specialists is very hard to deal with, is the diabetic macular edema post-pars-plana vitrectomy. As we all know, when in vitrectomized eyes, we don't have reservoir for the anti-VEGF. So here I'm using the suprachoroidal space as a new place to deliver the drug and a new basement for it. So I took 10 patients and followed up them. The criteria, it's a retrospective, but the criteria was at least the diabetic macular edema appeared after 6 months of the pars-plana vitrectomy, and there was no silicone oil. So I injected them, and I had a very good results. Due to the limited time, I cannot show the pictures, but some of them has resolved edema within 24 hours. So it works, and it works very well. And for pseudophakic cystoid macular edema, also I did a case report to inject triamcinolone for this patient that didn't respond well to topical NSAIDs, and I had also rapid results. The idea here, some of you can tell me why not to put Ozurdex. I've come from a place with a very limited resource. Patients cannot afford it. This triamcinolone, the injector is made in-house, so anybody can inject it with a minimal price, and you can have a result that's somehow similar to the Ozurdex. Thank you very much. Any questions?
Thank you, Amin, for this excellent presentation and good series collection. Is there any comment or question to Amin about his presentation? I know you answered my question actually, why you don't use Ozurdex, but it's a cost-wise. So approval, not approval, this is something also we don't.
It has an FDA approval for non-infectious uveitis, and especially if the case with macular edema. I didn't present here the cases of the
diabetic.
No, not diabetic, the uveitis. It works excellent with the uveitis, especially Behçet disease, or if we have an occlusive uveitis. So I know if you had an occlusive vasculitis due to prolizumab, you can rescue the eye with an Ozurdex. This may come with a cheaper price to save the eye.
Yes, actually, I was in the trial of Borussia. One of the patients, the 14 patients, is
Hello.
finally got 2020, and that was because I didn't pay attention to recommendations of the authorities of the trial, and I put in triamcinolone the very first day. So it's really using. I mean, triamcinolone is a very old drug, and sometimes we are not using it the way we should.
Um, I will give a talk about DME and real world experience with also another type of steroid of management of diabetic macular edema. Um, this one is the long acting steroid. First of all, I'll give a little bit hint about the diabetes mellitus, especially in our area. In UAE, it's very high, and we are ranked 15th country in the worldwide as having a high incidence of diabetes mellitus. It is now, before it was previously up to, I think, 2016, something like that, it was about 19.2. Lastly, within the last 2 years, it became 16.2 or 16.3, the prevalence of diabetes. So macular edema, as all of you know, it's a common feature of retinal disease. So it's not only for diabetic macular edema. We can find it with vein occlusion and uveitis, with AMD and other diseases. Retinal disease is a multifactorial. This is very important. It's not a single. And one of the most important one is inflammation, is a key component in the pathogenesis of retinal disease. You can see it is more common, obviously available with uveitis, and it can be also in the retinal vein occlusion, either central or branch retinal vein, and it can be also available even with age-related macular degeneration. There is some sort of inflammation. Maybe it is less in comparison to others, but still we are thinking there is some role of inflammation in wet AMD, and also in diabetic retinopathy. That it's very well known and the most important for us. I know uveitis is very important, but it is another entity we are going not to talk today. We are going to concentrate on diabetic retinopathy and diabetic macular edema. So edema, it's an imbalance between fluid entry and fluid exit. Fluid entry it will be increased from the vitreous and the vessels, and there will be a leak. And those they are producing or decrease, it will be fluid exit, it will be bimolar cells and retinal pigment epithelials. When we are having this imbalance, then we are having an edema. So here I will not go in details, but one single thing is that pro-inflammatory cytokinase produced by retinal pigment epithelium and glial cells play a key role in the DME development. Because I'm concentrating about the management with steroids, so I'm concentrating about the inflammatory process that happened in diabetic macular edema. Also, the cytokines produced by the retinal pigment and microglial cells will then, in turn, also act on the endothelial cells and leads the formation of edema. There was an evaluations for the inflammatory cytokines in the aqueous in human diabetic retinopathy, and you can see they are increasing, and there is a correlation actually. Vascular endothelial growth factor is highly correlated to BDR, not mainly to DME. There is, but we are thinking the DME is more associated with cytokines more. They will find according to the BGO, this is a diabetic retinopathy and inflammatory disease. They have mentioned that inflammation may represent the initiating and final common pathway leading to the complex pathology that is diabetic retinopathy. Also, they found that the vitreous fluid level of vascular endothelial factor and the cytokinase, they are well significantly increased in a patient with DME than in non-diabetic patient or diabetic patient without retinopathy. So if we are comparing this is also some study shows that there is an association of the presence of inflammatory cytokinase in the patient of diabetic macular edema. I think this one most of you know how the DME treatment of revolution happens and evolutions, and we have also another two drugs coming, brolucizumab and faricizumab. So our experience in our hospital, real life, this one we are using. I was the first one use this fluocinolone acetinoid, Iluvien, in the Middle East to treat the chronic diabetic macular edema. Iluvien implant, it's non-irritable micro implant containing about 190 of fluocinolone acetinoid, consistent daily sub microgram delivery of about 0.2 microgram up to 36 months. If you want to physically about what are the dimension, it is around 1 to 3 of the dimension less, I mean, in comparison to dexamethasone, which is the Ozurdex. This is some cases. I select some few cases to show, and this actually the first cases that I treat them now more than 6 year, around 6 year or 5 years and a half. This is a 70-year-old female patient, diabetic and hypertensive. The right eye is pseudophakic, left eye cataract, best corrected visual acuity 0.1 and the left eye 0.05. Fundus, both eye severe, non-proliferative diabetic retinopathy with clinical significant macular edema, and the OCT was around 700 in the right eye and also about 700 and something in the, 650 and 700 in the left eye. So had both of them several anti-VEGF before we shift them, and also dexamethasone implant injection before we decide to move and give a long-acting steroid like Iluvien. So if we start with the right eye, this is the patient. The baseline was best corrected visual acuity, as I mentioned, 0.1, and central retinal thickness was 650, intraocular pressure around 17, so it is good. There is no contraindication or increase in the intraocular pressures. And then after we said many anti-VEGF and Ozurdex injection, we decide to give an Iluvien. This is a 3-week post-Iluvien. The vision improved from 0.1 to 0.25, and central retinal thickness decrease, and the intraocular pressure within high normal limit. 8 weeks, this one there is a decrease in central retinal thickness again, but the pressure little bit high. But this type of pressure, I am not giving any medications, just to follow up to see if it goes more and more, then maybe I can give anti-glaucoma. And the vision improve also to 0.3. Then 22 weeks, the vision little bit go back. It was 0.3, now it become 0.2. Central retinal thickness increase, and the pressure is within normal limit without any treatment. In this case, we have given a top-up of the medications. So we give another, actually 3 injection of Eylea. I give the first one and the second one. We see there is not much different. Then I continue up to 3 injection. Usually nowadays, after a lot of experience, because these cases I'm showing is an early experience with Iluvien, but now most of the time I'm giving only 1 injection, or I can give 1 steroid, dexamethasone, and I will tell why later on, when I will select the anti-VEGF and when I can select the dexamethasone. This is the patient on the OD also. So best corrected again after we give the injection. So 9 months post Iluvien, you can see the vision became again improved to 0.3, central retinal thickness become decreasing. So 1 year, you can see almost there is a drying of the macula. And after that, there will be when 18 months post Iluvien and 3 anti-VEGF, we have almost 230 almost dry. There is some sort of epiretinal membrane, you can see it there, but not an indication for a surgical intervention. And this is how the patients now vision improved to 0.4 from 0.1, and the central retinal thickness almost within normal 230. The same patient also, this is a left eye. Here I will be very fast. So the baseline 0.05, as I mentioned, 700. Usually I start with the patient that time, so to help the patient to improve which one is good eye. So just to give a chance not to lose that patient because of ischemic changes and other things. In the chronicity, it will may lead to maybe we can decrease the central retinal thickness, but we will not improve the vision. But if we decide early switching, and this is my recommendation now, I'm not waiting up to 6 injection. I know there is a conflict about this one, some of them 3 and 6, but most of the time after 3 injection, if there is no response, I go directly and switch to steroid and not switching to another anti-VEGF. So here the patient in the 3 weeks, you can see after that we give Illuvian. After 3 weeks, he improved to 0.4. You can see very nicely. Then after that, he decreased after 22 weeks. Then the vision drop again. And this is actually because, as I mentioned earlier, he is having a cataract, and now also more cataract he was having. So that's the case of why the vision is dropped. Even the central retinal thickness is not that much decreasing. So I give again here a steroid. Sometimes you need a very big amount or more concentration of steroid to work. Maybe the slow releasing small amount, maybe it can give you just a constant and stabilize the vision, stabilize, not to increase, to have increase on central retinal thickness. But if you give more steroid, that's what I found, then like other decks, one time you will find there will be a very good response. Then the Illuvian, it will continue the job by maintaining the vision and maintaining the central retinal thickness. This is after 9 months. This is after actually 1 year, so 0.3. Then here 0.4, he was improving. Actually, this is a report about different of cases, that 6 cases. Actually, now I have more than 50 case already, and I presented yesterday another in another sessions about the other one. But here I was concentrating just to give you the early that they finish almost more than 5 years experience with Illuvian injections. They are having a very good achievement about the central retinal thickness drop or decreasing the reduction, and also improvement in the visual acuity. So in the beginning, this one, the earliest experience was total number 6 case, average central retinal thickness reduction 1 to 3 weeks post Illuvian, about 70 to 80 microns. Average central retinal thickness and 22 weeks post Illuvian, about 200, and average best corrected visual acuity within 20 weeks it's 0.2, and average top up within 1 year after Illuvian about 2, either one Ozurdex or 2 anti-VEGF. The take-home message from this is that around 20% of patients need top up after Illuvian injection. Top up with steroid can be done if the baseline of the edema was high. So those they are having a very high central retinal thickness, more than 500, 600, 700. Most of the time I found it's need more concentrations of steroid is needed, more inflammatory, and sometimes associated with a more inflammatory process. Top up with anti-VEGF if the baseline edema is moderately high and you feel no sign of inflammatory process. Usually consider top up only after 6 months. Usually we are not giving any top up before 6 months, even if there is no response, because most of the time we can find the response, it can happen after 6 months of Illuvian injection. So in conclusion, published data and local experience with Illuvian suggest that continuous microdosing achieve significant improvement even in difficult patients. Continuous microdosing with Illuvian carries both anatomical and functional benefit. And thank you very much. Any questions?
Thank you very much, Dr. Al-Amri.
Just one question. For us, I'm very interesting because we don't have Illuvian in Argentina and Brazil. We don't have it. So my question is, when you have a patient that needs steroids, what do you prefer to use? I mean, comparing Ozurdex and Illuvian.
okay.
Of course, it depends on the case, but guess that
Yeah, in
you
general.
need a long treatment.
And why? Yeah, I will tell you. You're very nice to say it and why.
Okay.
Okay. First of all, in case of most of the time, as you know, Illuvian have two type of approval. In the United States, you have to give an Ozurdex as a test for the if there is a response for the steroid or not. And in Europe, no, they can go directly after the anti-VEGF directly without using any dexamethasone or any test for the steroid responders. This is first. So there is a lot of things related to that. It's not one things, but the most important is the patients themselves. If they are very compliant, they are coming to me. I will not go for the long 3 years. Okay, but in case they are not responding, and also I'm giving steroid and there is no much reduction, you will astonish. I don't know. I cannot explain why, but we are giving anti-VGF. Then after that, we give also Ozurdex, and there is no response that much. They are not responding well. So this is one of indication that I will give steroid. The other one, if there is no,
That's a point.
yeah,
Because it's not just because you have a new tool that is, I mean, long lasting. It is so.
no, there
If
is an
maybe you are treating a patient with Ozurdex and it doesn't respond, so you use Illuvian
yes,
because
I
you
think,
feel
yeah.
it's better.
Yeah, this one of the things. Also, during the era of COVID, we are having a lot of problems. So many hospitals, even our hospitals, that we are switching or closing all the surgery. The follow up, it was very difficult, especially in the beginning. You know, in the beginning, everything was, afraid about the contagious of the disease. So in these cases, I don't want to just to keep the patient without having any treatment. Some of them they are refusing, but at least I can give something that it can work for a long period of time, and then I can bring them not, I mean, so frequent. The follow up it will be very less, especially because the dose of the steroid. If you compare the dexamethasone is about 700 or zero point 0.7 milligram in comparison to 0.1 or 2 milligram of the Illuvian. So the concentration is less, and then you are not afraid of having an increase of intraocular pressure. I know some of you that will say maybe it's an accumulative effect of the steroid, but sometimes you will feel, I will find of them, they are in the third month, they will have, or second month, they will have an increased intraocular pressure. So I will bring them at that time. I will see if there is an increased pressure or not, intraocular pressure. If not, then I will give another 2 months and again. And I'm instructing the patient, if you have any pain, if you have any drop in the sudden of the vision, even I'm giving my mobile number. They can call me anytime for these patients.
Okay, but I want to add one comment, please. I don't know what the rationale of adding up steroid over steroids. Even it wasn't responsive to anti-VGF. We have to understand something, that the pathological the pathology behind the diabetic macular edema is multifactorious. So I think, in my opinion, that to add anti-VGF, it wasn't, even if it wasn't responding at the first to the anti-VGF, but and we switch to steroids and we might have a non-complete responder, we should add anti-VGF, because we have to remember one thing: there is a concept called late responders even to the anti-VGF. So I think adding the anti-VGF is more rational than adding up steroids that way, which may increase the intraocular pressure. This is the first. Second of all, the study, the FAME study, I guess, that gave the FDA approval for the Illuvian. It's been such as like artificial environment that we cannot put it in real life practice. The real life reports is saying that it will last up to 1 year, or after 1 year we might add anti-VGF, but we won't be the same intensity or the same volume of anti-VGF as we do without the Illuvian. And third, why not adding laser? Especially at the era of the microsecond laser, we can add it if we have a non-central edema adjacent to the or in the light of presence of the Illuvian. That's what comments I have.
Okay. I think maybe you raised 3 points regarding the first one. Why not to give anti-VGF instead of giving? Why you give steroid? As I told you, there is no rule or there is no study to show can use steroid, but it is a speculation and it is experience wise. I'm not telling this is a rule, but I found that whenever you are giving a steroid, why we are switching to steroid at the beginning? At the beginning we switched because we didn't find any response from anti-VEGF. About the era that some of them they are having a late response, we are already now giving a 3 months maybe or 5 months of anti-VEGF, and I give Ozurdex and there is no response. Now we are crossing almost 9 months with the patient. So I don't think, sometimes yes, it can give, but also as I mentioned, that's why in the beginning of this lecture I tell you there is a role of inflammation, and we have to remember that DME most probably related to not only anti-VEGF. DME is more related to the inflammation rather than anti-VEGF. There is an anti-VEGF, but also steroid can work in both, in anti-VEGF, and also can work on cytokinase. That, but while anti-VEGF is work only in one. So in speculation, we are having a medication that can work on both pathway, either against the cytokinase and also against the anti-VEGF. It is There is no study, but regarding the top up, there is a study. There is many real life experience happen now, and it is completely different than what is happened in the film. Some of the study, they are using an Illuvian as a first line of treatment, and I have an experience. I didn't mention this one because I don't want to go on this, but I have so many cases as a naive patient using with Illuvian. There is some report about the Illuvian to be used as a naive patient, and also top up. It can be most of the time as recommended by many abstract, my real life experience, to be after 6 months. It can be more or less. I mean, most of the time we found it 20, 18 weeks, but it can happen, and it can be started after 6 months. Sorry. Yes. I don't know if the last one, I don't.
There is one just more comment on it. Actually, diabetic retinopathy and DME is a topic on which you can talk hours and hours and it doesn't finish actually. What I understand is the main problem behind diabetes is microvasculopathy. And that actually leads to some kind of ischemia. And then ischemia leads to inflammation and all that thing because of the oxidative loads. So what we are treating, actually we are treating the branches and fruits of the main problem. We are not actually treating the ischemia. So sometime in future, people like Amin Marashi and must do some research on this product. How can we reduce the oxidative and injury load on the cell? If you prevent the ischemic injury on the cells, you may treat the diabetic retinopathy. We do cabbage, bypass here. We can't do bypass on the retina. But if something comes later on in future that you can do bypass in microvasculatures, or you nullify the antioxidative load, that's why I was telling that antioxidants treatment, they do help in AMDs and DME, which have got basically an ischemic pathology. And what they do is that ischemia causes some pathology in RPE, which is the basic scavenger of the whole thing. And then the whole process starts, because you might have unhealthy photoreceptors, and if you have a healthy RPE, you have a chance to survive. But if you don't have a healthy RPE, you might have healthy photoreceptors, they don't survive. So the basic pathology is ischemia, and that leads to inflammation and all that. So by treating with steroids, etc., we are treating a kind of the byproducts of the main thing. So actually a little closer to the actual problem is the anti-VEGF, which basically treats that thing which first causes the problem with the diabetic, with the ischemia. But we should go a little behind, and we should try to treat ischemia somehow or the other in the diabetic retinopathy. In future, somebody will think about it.
I have one comment about this one. First of all, there is now new medications like faricimab. I don't know, you have it now there in Argentina.
Bevacizumab.
Faricimab. Faricimab. They have a faricimab. Okay. Okay. They have now the dual mechanism, and one they are claiming that is or prevent the destruction or the pathology in the blood vessels itself. So prevent the cells from damage. So we are willing to have whatever, but this is something we are using whatever it is in our hand. No one can claim this is the only medication. It will be a continuous controversy between all the doctors. We used before to talk about 6 months, and we spent many years. No, only after 6 months switch between anti-VEGF. Until now, some people they are believe. So many people now they are only early switching is make different. So The EME is a multifactorial. We have to know that one. Inflammation, one of them.
Can I ask a question, please?
Okay.
I missed part of your lecture. What is the cost effectiveness of illusion? Because we are not having it here in our country.
Oh, okay. This one another good questions. Actually, it is about $10,000.
$10,000.
Yeah, but listen to me. If you calculate it, I have done a calculations about this one I mean, to ask our yeah. It is you if you find it if you give Illuvian injection for and it works about let us say about 24 to 30 months. Okay, that means 2.5 years. Okay, I will not say 3 years. How many injection you will give and what are the cost? Most of the time, if we just have it alone without any top up, it will be less. And economically, it will be less costly. Maybe as a one shot, it will be big. But if you add what you are giving as an anti-VEGF or Ozurdex, it will be more. If we are treating the patient according to the the regular way, you have to give 7 to 9 injection in the first year. Then you have to give another. This is a yeah. This one is different. I know, huh? Yeah, yeah, 15 to 18 sometimes. Yeah, between calculated, it will be more costly. And even you are exposing the patient to a pain, exposing a patient to another need for that patient. He's coming every month for follow-up, for injection, distracting, or the family, many things. If you calculate it, it will be very less.
Well, you have in shows, there's no problem. But we are talking about a country like Pakistan, where even, one simply, we will still have a big issue.
Okay.
Costing $10,000 for a single.
Let me answer that because I've come from.
Something will cost nothing.
I came from a low-resourced country. Our patients cannot afford Eylea by any means, so I inject Zaltrap. It works beautifully. I've been using it since 2015. It is just perfect. The same results as Eylea. The second thing, before 2018, I used to inject Ozurdex. Some of patients can afford it, and I switched them to the suprachoroidal injections. The only difference is the durability. Ozurdex can live up to 3, maximum to 4 months. Here, 8 weeks, like a Cinderella. After 8 weeks and 2 days, the edema recurs. That's the main problem. But it is very cheap. You can repeat it, and it's safe. The safety profile is good, especially in terms of intraocular pressure. I didn't have an increase of intraocular pressure more than 30, and only in 15% of cases.
Can
So-
you just, if we can, because we are running behind the time,
Okay,
so if we
okay.
can just shortening the answer as much as we can, if possible.
I have just one comment. As you said, diabetics are multifactorial, and the steroid, it's not only anti-inflammatory, but it's anti-VEGF as well. And then they cover almost everything. That if you think that at the beginning of the diabetic, the macular edema is driven more by VEGF, but with chronicity, gonna be more inflammation, but still VEGF, the big factor for edema. And we don't have the correct date to say, oh, I have to inject anti-VEGF or a steroid. But if you inject some anti-VEGF, it doesn't work, it's reasonable to try a different path.
Yeah, that's what I have said. I mean, no, there is no rule to say I will inject anti-VEGF. Most of the time, we would like to inject only anti-VEGF. But I feel with this, with Iluvien now more than 50 case I have, those they are having a high, central retinal thickness crossing 550, 600. And you give Iluvien after all anti-VEGF and Ozurdex, and there is no response, and you give Iluvien, and you want to give a top-up, and the central retinal thickness doesn't go very well, it will not go by anti-VEGF, by one anti-VEGF. Because I will show you, there is one patient, maybe I have given 3 anti-VEGF. 3 anti-VEGF just to have decrease the central retinal thickness a little bit, and then the Iluvien will work, or continue at least in the steady way. Yeah. While in Ozurdex, you are giving only 1 injection, then it will decrease, because this is another problem we have to think about. A continuous having of high central retinal thickness, it's one of the main factor for I mean chronicity and ischemic changes. Whenever you are having an ischemic change, then there will be no benefit or improvement in the visual acuity. Okay. So we can move to you, Mario.
To me?
Yeah.
Okay.
Yeah.
Well, so thank you very much. Uh, we are having such a good time here. You are very kind. We really feel so good. But talking about what we are working, what we are discussing here, uh, it's so, how can I say, but it's so uh, enrichment to have these discussions with you, because I can feel that we have the same kind of countries, the same kind of patients. We are not talking, when you're in other meetings, you start to tell your, okay, the pointer, which one is it? This, one is a pointer. And yes, when maybe they tell you, okay, you have to put 10 illusions or something like that, and my patient in the whole life are going to earn the money for that. So it's so good to see you. I'm going to talk about pegcetacoplan. The reason I send my talks focus on new drugs. I am a surgeon. I have my practice is I am a surgeon, a retina surgeon, but I'm running a clinical research center. We are running like 16 clinical trials right now, and maybe I think, especially because I knew I was coming to a country like this, I knew I didn't have too much to show about surgery, because and I confirmed that, because you are very good surgeons. When I have challenging cases, surgical cases, I took them to Italy, to France, to all that, to the States, because they don't have the patients we have here. Well, so this is why I'm bringing to you this new expertise. Of course, I work for this for this company, Sapelis. But let me remind you the natural history of geographic atrophy. I'd like to know from you how much, if you have if this geographic atrophy here is a problem, is a health problem, or you don't see it that much. Many cases. I think yes, because there is something very strange uh, about the concept in central countries they have about our countries. They say they are looking for doing this kind of phase 3 clinical trials in Argentina, because they say that, okay, you have many European people because of the immigration or whatever, so maybe you have these patients, because we don't have that much in other countries, and that's not true. That's not true. You have many in many, and as long as we can get a better lifespan, this is going to be a real problem. I mean, actually, the incidence of geographic atrophy is the same than exudative, but the problem is that we don't have it. It works under the radar, because we don't have anything to do, so we say we don't give too much expectations to the patients, so patients don't come again, and we focus on those patients we can treat with anti-VEGFs and whatever. But just to remind you, after when a patient, when appears a first lesion, an extrafoveal lesion, it takes like 2.5 years to involve the center of the macula, and that means it's too fast, and so this is why if you can not
not don't, let's not say stop, but reduce the natural progression. In a 25%, you get a lot of time with foveal survival. And if you get like something like 50%, of course this is the double. Uh, and, well, and the pathophysiology about this one is it works over the complement cascade. Of course, we all have complement cascade working every time and triggering every single millisecond in every tissue. But we have our when we are since we are healthy, we have our own breaks for this process. But when you have a pathological situation, those breaks fade. Well, this is you can find higher levels of complements in AMD patients, and this is it. Basically, you have three ways to activate the cascade, the complement cascade. Of course, as a surgeon, I don't like to talk about these cascades or whatever, but anyway, we have to talk about them. The classical is the one that is activated by an anti-Asian antibody complex, but you have an alternative pathway and the lectin pathway. This one is activated by the polysaccharides in the surface of the bacterial membranes. And this one is just because, I mean, the alternative pathway is a self-activating of the complement cascade process. But all of them are together, gather in the C3's activation and the C3 activation. So, but if you are healthy, you have your breaks. If you don't, you trigger the membrane attack complex. That means that when you have this cascade activated and you cannot stop it, the membranes of the cells around are going to be damaged and the cell will die. This is a simplification, but just to show you that makes sense to block the C3. There are other drugs in study. We have another trial for GA also that targets the C5, but C5, well, it's different. Now we are talking about this drug, pegcetacoplan, and it makes sense to block this C3 process. So what do we have here? It is a peptide, a pegylated cyclic peptide. It is a C3 inhibitor. It is delivered intravitreally. And let's talk about the phase 2. The first study was phase 2, and then the phase 3, the Derby. We just finished Derby 1 month ago. So this is very fresh information. So, well, again, we are trying to block the C3 with this drug. And the phase 2, Philly, we were the patients randomized in 43 sites, randomized in a 2-2-1-1 manner. Well, actually, we are just treating patients every single month on every other month, and we have another control group for the two groups. So that's why you have 4 branches. And look at it. This is the first, after the first year, the difference, in between these patients that they received sham injections and these other 2 lines receiving every other month injections or monthly injections. You can see you have a difference of about almost 29% and almost 20 in the every other month. But what is interesting is, well, maybe, in these cases, in these trials, sometimes you can, not you, but the companies or whatever, you see that they don't break the law, but they try to bend the data. Yes, they try to manipulate. If they are still uh, uh, inside the law, they could do whatever. But this is interesting. Look at what happened, because we follow the patient for 6 more months, but doing nothing, giving them nothing, and they recover the curve, and that is true. In the phase 3, and of course, the best. This is very important. We didn't find an improvement in visual acuity, but that is not something too bad too, because the problem is that these are patients that are very in the edge. They are losing their vision, just and this treatment only slow down a little, but they don't stop. So it's something logical to find this. But this is a very, very important problem with this drug. Many of these patients, when I say many, uh, some of these patients really convert to exudative, to neovascular AMD, and they, as you can see, look at in the sham group, it was about 1%, but it is like 9% in the every other month group, and almost 20% in the monthly group. So it is they produce neovascular AMD in a doses dependent manner. The adverse effect, there's nothing interesting, and so they jumped to the phase 3, and it's basically the same design. One thing that is interesting, maybe for you to, because after you hear this, you may say, well, okay, if I have a patient with GA here, what can I do? Or, well, maybe you can get the first thing you need to do, you need to know if this patient could be helped by this drug. And the way, of course, you have many different, but the thing that is very, very, very important is the hyperfluorescence, this one, the perilesional hyperfluorescence. I mean, if you got a patient with GA, take an autofluorescence, and if you see at least a little hyperfluorescence in the edge, this is a patient that could be helped by this treatment. If you don't see that, there's nothing you can do. And again, you see the differences are a little lower than in Philly, but they are consistent. And look at this. This is very interesting. If you compare with the other eye, that in bilateral GA, you see that there is a difference, and you see in the fellow eye that there's no difference in the surface of the lesion, and it's the same in Oaks. These two studies are twin studies. In Argentina we had this derby, and this is also important. This is very interesting. The treatment seems to work better when in the extrafoveal lesion. So the sooner you get the patient into this treatment, the better for him. But if it's in the edge of the foveal lesion, maybe you have nothing to do, because I insist, this is not to stop the disease, but to slow down it. Finally, the conversion, this is consistent again. Look at the sham group, we have almost 3%. Look at the every other month treatment group, you have about 6% and a little more than 9%. So it is very, very consistent. The dose is dependent manner to produce neovascular disease. So the take-home message, just slow the progression. This is not a cure, but it's something. It's the first thing. And we have in the pipeline many studies focusing on GA. There is something very interesting about what you say, trying to improve the irrigation in diabetic patients, because we are ready to start next month. Very interesting trial. It's a phase 1 with using a catheterism to the ophthalmic artery to improve the irrigation in patients with GA. And they have in the previous experience, they have very good results. So let's see what we can find. So I don't know if you were just creative or you had information, but I was thinking, well, this is something strange. Okay. Treatment should be sustained in time. This is very important, because if you suspend the treatment, you recover the rate of growing of the lesion, and the risk to develop NAMD is very important. So keep it in mind. You have to follow these patients. Actually, we got patients with this shift to NAMD, and of course they are in the protocol. So we are seeing them every single month with all the assessment. So we pick them very early. So if you treat them, that's it. You don't need to. With John, yes.
Okay, thank you very much. First of all, do you have an OCT angiography for those patients which develop neovascular AMD? Because there might be a non-exudative AMD or a treatment-naive CMV or a neochoriocapillaris due to the suppression of the inflammatory cascades they provoked and developed, because we are manipulating here the mechanism of defense of the eye. That's
Probably.
That's why. But do you have this data?
Yeah, well, we are touching a very exquisite balance. But if you are asking me if we have angiographies before, yes, these patients, they every single month they come to us, and they are like, I don't know, 6 to 8 hours with us, doing different types of OCT, OCTA, angiography, whatever. So we got everything in the screening visit. We have
any difference pre-treatment on the OCT angiography on those patients, with those patients didn't develop neovascularization?
I mean, are you asking me if they were virgin, naive?
No,
or not?
No. If the patients has subclinical membrane without any exudation before.
No, at all.
We
telling
checked
you
before.
that
We
they
checked.
were very well assessed, and it's not. We make the studies, but we put it all together and we send them to Boston. So in Boston, they say, okay, yes, Boston, the reading center. We send them to the reading center, that sometimes is Boston, Duke, or Bern in Switzerland. So they are very close follow. No, they are really, they don't have any lesion.
Another important question: the drug you told us about, it's available in the market under the trade name Impavali to treat.
No, it's not available yet. It's it's ready to be approved, or I don't remember if they approved
The-
just
No, I'm
No,
not
no,
talking
last
for
week-
intravitreal injection. I'm
Yeah.
talking to treat hemoglobinuria. It is Empavali, the same molecule, but different dosage.
You mean the systemic use
Yes,
of
the
for
systemic
C3 block?
Yes.
That we have been used this for a different disease.
Yes. So,
okay.
okay. As I did a little bit of research for it, it's the identical but different dosage. What you are using in your clinical trial is, I think, X4 or X3 from the dosage that available with Empavali. So, in your knowledge, is there any difference in buffer solution? Can we use Empavali? Like us, the low resource countries, because Empavali is extremely cheap drug. So this is the question I was
I don't know.
trying to search for it, and nobody gave me a cut for it.
We don't know that
don't
just
know.
because we have to research if the molar equivalence of the Epavali and the if they so acid or not that you can inject in the eye, like the fiberfeps that you
Zip,
said.
yes.
That's a fiberfep that
They
used
said
for
no,
cancer.
you cannot inject it,
Yeah,
and we published a
but
study
we have
of
this
about
research
6,000
if,
You know,
if
francs.
the equivalent.
I
the
like.
equivalent.
I am creative also, and I would like to answer you with my feeling, but now working as a principal investigator, like since more than 20 years ago, I have my mind set up, so I can't say if we don't have a comparative trial, we can't say that.
So you think-
But if I have, but I live also in a low income country, and if I had the chance to try it, I would try it. There is something special that I would like to tell you. I mean, my insight, being working in this study, that the genetics has a lot to do with this, because there are some of our patients that they respond, because I'm showing you the average, but there are some patients that really respond, and some others that they don't respond at all.
Mario, I have two questions for you. I really appreciate very much your talk, and I'm just following the approval of FDA. Last week was first the FDA just wrote down some questions for the appeals.
Yes.
Yes.
Because I was talking with some guy
Yeah.
in the board, and they told me we expect to be approved before the end of
the new year. Maybe next week gonna be approved.
Yes.
They have to answer some questions from the FDA. But two things. First thing, we just buying time because the lesion still grow, but we're gonna slow down like you said. When this lesion get the fovea and the vision we're gonna drop, you still inject in this patient, because for the patient gonna be my vision is not good, but you think that in our
Well,
mind we're gonna
yes,
spread the
I understand your question. Yeah.
Yeah.
And for those who are as old as me, we
use
are
laser.
No, I remember when you well, maybe that's to be
Laser.
too old, but no. Do you remember the Visodine times? Yeah.
Yeah.
Well, when you had to tell to a patient, okay, you have to pay this amount of money, and we are going to make you 2 or 3 treatments, and you're going to be blind anyway.
Yeah.
But so it was, yeah.
Yeah, more time. And
but-
more old than that, when they said the patient, okay, go home and try to read if you can read, but tomorrow gonna laser you, you're gonna not read anymore.
No, but then
For
well,
neovascularization,
at that
the old
point,
times, the MPS. studies.
last month I had a talk with one of those patients. Actually, his surname was no, was Armenian or Isian. That doesn't mean because, well, but anyway, he was in this position. He was an engineer. He's an engineer, and he's telling me, I'm here in this study for
Scotoma gonna grow.
for 2 years, and I'm losing vision. And I don't know if maybe this is the reason I'm losing vision because you are treating me. No, checking. We have, as he is an engineer, we did something that you cannot do. So don't tell. But no, I put it in the other side. I put him in the other side and showed him the way we were stopping the lesion in his treated eye and what happened in the fellow eye. Because in the fellow eye, he didn't realize that because he already had a lesion. So, and that's why I say, okay, I'm keep on treating. But it's difficult because from the perspective of the patient, this is the
Is there
situation.
any protective?
Excuse me, I mean, I think we are running behind the time. If there is because they want to start there. Okay, we
Okay,
can
okay.
have it in between. So if you want to allow me to conclude this session, I will thank you all. Thank you
Okay,
for
thank
this
you.
excellent talk, and we hope to see you, inshallah, next time also here in Lahore, as you like Lahore very much.
Thank you very much.
Thank you very much, and thank you for all.